So I will first give the floor to you. Later on I will try to wrap up and make your first sip of tea even more virtual. I will not give the floor to everybody. I will be very selective. I start with reservation. Are there any nurses or midwives in this hall? They have the floor. Can all nurses and midwives raise their hand, please? That makes a plain zero. This is a session on human resources. There's one? I'm so glad. You have the right to ask the first question then. Well, then you can start. Why do I do this? To make us realize that if we talk human resources, we shouldn't only talk doctors. You have the floor, ma'am.
Thank you. Looking at providing universal coverage, health coverage, and trying to address the deficit and finding innovative solutions, I just would like to call attention to the recent news that we have been reading about the MCI introducing a new course and creating a new cadre of health workers by offering them a 3.5-year degree in community health. My submission here is that we already have nurses who undergo a 4-year degree course. Why can't we look at them and provide additional training, as has been highlighted yesterday and today, the concept of the nurse practitioner in India, if that can be advanced, and if nurses can be given a scope of practice which, within a legal framework which allows them to treat and diagnose, treat patients. I think, as has been pointed out in your presentation, that they are willing to work in rural areas, and we are increasingly seeing that. So I think the recommendation here should be to look at the existing cadre of health workers rather than, maybe the MCI move has potential, but we should also think of the career progression of the existing cadre of health workers and see how we can bring them into the, trying to address this scarcity. Thank you.
Thank you, ma'am. Before giving the floor again to the panel, let's take 3 questions. Who wants to ask the question? There's 1, 2. Let's start with the lady, then we come here in front, and there will be a 3rd one. Please present yourself.
Yeah, good afternoon, everyone. My name is Dr. Nidhi Bhatt. Currently, I'm working with Microinsurance Academy. I think in all the presentations, all the issues have been taken very well. And coming to the presentation from Odisha, there was one point on the resentment against the bureaucracy and the behavior of the PRI members and other things. So if we talk about the client satisfaction as a quality parameter, what we are doing for a provider satisfaction on a regular basis, what is the policy uptake for it? And if we are just considering salary or financial incentive as the only way to increase the motivation, then what is the consideration for the grievance redressal by the policymakers? I hope.
Here, please.
I'm Dr. P.H. Rao from Center for Symbiosis of Technology, Environment and Management from Bangalore. The so-called HR dimension will be completely different if we can get away from the obsession with the so-called numbers, norms, WHO or whoever norms it is. And instead of, if you talk about universal health coverage, but if you talk about universal health access, issue will be completely different. My question is just 2 points. Are our primary health centers, community health centers, or district hospitals are open? Are the doctors available at the time when it is convenient to the patient? Or is it open at the convenient time for the doctors? I think this is a serious question we need to address. When Apollo or Yashoda or Kamineni can have evening clinics, they clearly say that because it is not convenient for you to come to us during the daytime, we are opening in the evenings. Why can't we do it? You can have any number of doctors, but access is not there, then the problem is not going to solve. Number 2, do we need a MBBS doctor for each PHC? There is anecdotal evidence saying that Some of the PSCs have better attendance when a doctor is not there. All the problems which are coming to the primary health center, do they need a attention of a primary, an MBBS doctor? Why can't we have, suppose if you say in the norm, instead of one doctor for one PSC, if you say one doctor for two PSC, I think the complete dimension will change. Your perspective, HR perspective will altogether change.
Thank you. We had the third participant in the back.
This is in response to Indira's presentation, where the infrastructure was the number one reason for doctors to prefer rural areas. My name is Giridhar Babu. I work at PHFI's wing at Bangalore. The question is, in the experience of Karnataka and Andhra Pradesh, even with the state-of-the-art centers done by KHS, DRP and similar cooperation in Andhra Pradesh, doctors are not staying in rural areas. Did you consider this as evidence when you are concluding from your research?
Okay, we keep it with that, with the 4 interventions and at least 3 questions. Who wants to take on of the panel? Okay. Do we have a mic for Krishna? Yeah, please.
So I'm just going to answer the question on the first question on nursing. I entirely agree with you. I don't think there's any reason why nurse practitioners cannot be tried in India, especially for the primary care level. They certainly are they certainly are used extensively in countries like the USA and the UK. There's no reason why in India we can't do it. I think there are power dynamics between doctors and nurses that would come into play when you're trying to introduce a nurse practitioner type of cadre that need to be taken into account. I also don't know of any experiments that have been done in India where nurse practitioners have been used. If there are, I think these should be evaluated and the findings of this seriously disseminated and studied. The 3-year doctors have been done in 2 states and there's been research done on them. But if the same thing is with nurse practitioners, I think they should be used. In fact, it's a lot easier to have nurse practitioners because of an existing cadre than to create a whole new cadre within the system.
Can I also respond?
Of course you can.
I'd like to also respond to that about, as is pointed out that nurses are willing to stay and work in rural areas. See, one observation that was there in our study. See, we need to consider, I think, the whole social background. By and large, possibly nurses belong to those areas, belong to those districts, and they would like to then work there. If you look at the social background of doctors, that just does not hold at all. Much of the doctors are from very urbanized, quote unquote, not backward districts, and that is a very important factor which we completely miss out. Now in this study, we have looked at the districts which has the most number of doctors, and interestingly from the KBK districts there are hardly 2% doctors in the entire Orissa government health service. There are absolutely no doctors. And that is why I mentioned that issue of these being largely tribal areas, and there's just not a single doctor. And so we need to look at this issue of these whole inequities in education at the larger level, and within that in medical education specifically. I mean, obviously in such a short time it was not possible to cover it, but the report has all the details. That's a very major issue, and there are experiments we know in the Latin American countries where you get doctors from the community. So they come, they study, and then they go back. See, when I talk of the larger issues, this is a major issue. So maybe we need to explore that why nurses are willing to work but doctors are not. Why don't we have doctors from these areas, from these so-called backward areas is the question. And I'd just like to combine that with what the last question that was asked, that do we need doctors for PHCs? Yes, I'm sure in certain areas you would need. After all, there's a whole thinking behind this whole 3-tier network of sub-center, PHC, CHC. What is probably being repackaged now as managed care and referral system and so on. So there was a certain thinking that went behind as to why you need a doctor or 2 doctors in the PHC, and then you need a certain number of doctors in the CHC. So these issues need to be kept in mind.
Thank you. Kedam, you wanted to add something?
I think to the Giri's questions that was to the Indira, regarding the infrastructure. The infrastructure available in Karnataka and Tamil Nadu is much very different what is available in Orissa. I can say that you go to the any PSCs, there are not buildings or accommodation, the quarters empty. They are filled. If it is for doctor, if doctor is not staying, somebody else is staying there. So we need huge, at least some minimum infrastructure to stay. So I agree that even we give the state-of-art accommodation, all these doctors or somebody are not staying there. But at least minimum required should be given. Not state-of-art, but at least minimum required, which is not there in Orissa at majority of places. Thank you.
Thank you.
Can I respond to some of the questions?
I think that we should learn to say what we want to say in 10 minutes and not make double presentations. Sorry.
No, some questions were specifically asked, so I was just wondering.
Well, I would propose then that you do that during tea break.
Yeah, okay.
Because tea break is over in 10 minutes and people have these necessities also. I will not wrap up for several reasons. First, because it's impossible. Second, because you have a second session on human resources later on. I will, however, add some questions. Are we doing this the right way? Are we looking at the right questions, and do we pose all the right questions? We have had very nice evidence today in this first session on human resources on what we should do to make the system better match the needs of the health staff. Shouldn't we also, when we pose these questions, at least pose the question, what will match best the needs of the population? Let me remind you something that dear colleague Professor Mavalankar said in the first EPHP 2 years ago here, how far we are behind in India with maternal mortality, and how our neighboring countries did so well with the same maternal mortality using nurse midwives which we in India deprived of their capacities after the Singh Committee in the 1970s, and we degraded them. So I liked it very much when in the introduction Sundarananam said what is really important is the right skill mix in the right person, in the right place. And I would add, for our people, not only for ourselves. And I welcome you in the afternoon for the other session on human resources and invite you now for tea or coffee. Thank you.